From Imperial College London, welcome to this special lecture vodcast.
Thank you for that extraordinarily kind introduction, and thank you for inviting me to be part of the Imperial Centenary. It is really an enormous privilege to get to be part of this, especially as someone who is still very much a young surgeon, feeling my way through what many people in medicine are all trying to do, which is understand what it means to be good at what we do. This book is, in many ways, a follow-on to my previous one. My first book, Complications, was at one level, like this one, just a book of medical stories. The difference is that I wrote that book as a trainee. It was started in my second year of training and on through what became a total of 8 years of training. And what I was trying to understand along the way, and I think it's what we all try to understand as we take on a task in this profession, is why does medicine fail? And if medicine is imperfect, what does it mean to try to learn to do something that is imperfect? In dissecting that question, it led to entering practice, which I started in 2003 as a general surgeon and an endocrine surgeon. And going into practice, you find that your questions start to expand even further outward. In entering practice, it didn't seem like it was enough to say, yes, we're fallible in medicine, and we try to overcome that. The next question is, what does it mean to really become not just competent, but actually great at what we do? In the course of practice, you end up recognizing that medicine is an unusual kind of performance. And it is one that is unusual partly because failure is incredibly easy. The other reason is because going into practice, you're grappling with everything from how to introduce yourself to patients to whether you have everybody on the team actually washing their hands or not. What it led me to recognize is that there are patterns that I wanted to understand to those who are great at what they do, patterns that could explain to me as I came into practice as still someone feeling very much a neophyte, where if I saw those patterns, maybe I could figure out how I could actually someday be really good at what I do. And then maybe by extension, from those lessons, we might all figure out how we in medicine become great at what we do. I'm used to turning to athletes to tell us something about performance. You know, it's interesting. If you pick up the medical literature, there's almost nothing that really tell you about what it means to perform. It's not something you find in textbooks. It's what people tell you about over the lunch table. Whereas if you read the stories of athletes, they will go into great detail about what it means to perform well. And so I've devoured these books. Unfortunately for you all, it's baseball that I love. And half of you probably understand that about as well as I understand cricket, which is still completely baffling to me. But what I take away from that are the values of hard work, of perseverance, of what it means to practice at something in a deliberate way. And yet, in athletics, it's limited. There's only so much that you can learn there because there are dimensions in medicine that simply are not to be found on the playing field. For example, number one, we have lives on the line. That is, we're a profession in which we take responsibility for people. And that means that we are taking on a moral task, and that's different. Beyond that, though, there are other dimensions that I think are very important about this particular human endeavor. A second is that we have a daunting ambition. It's to take all of the science and experience of centuries and make them available to an individual who's sitting in an office coming to you with a particular problem. And not only are you trying to do that for one person, we are trying to do it for people across an entire country, one person by one person, individual by individual, in a consistent way and reliably, despite the fact that there are all kinds of different people involved. In fact, this is a task that involves not just a doctor seeing a patient one at a time, providing the right kind of care and bringing that know-how of centuries to this one person can take hundreds of people. Think about the person who's in a hospital room at St. Mary's right now. They have all of the nurses on each of the shifts who must do their jobs right. You have the engineer who's responsible for making sure that the oxygen coming into that patient's nasal cannula is actually there 24 hours a day, consistently, at the proper mixture, never changing. You have the cafeteria worker whose responsibility is to put together the trays for lunch, and they have to make sure that the diabetic patient does not get the concentrated sweets, that the peanut allergy patient does not get anything containing peanuts. You have everybody all the way on down to the doctor, and that's why it can be hundreds of people who are required to be involved. And then we add on one final dimension. Not only do we want this work to be consistent, to be reliable, to be scientifically sensible, to involve teams of hundreds of people, we want the work to be done gently, with humaneness and concern. And so it's not just the stakes, the fact that we work with people's lives in medicine, that make it interesting. It's the complexity. In fact, I would argue that this is man's most ambitious endeavor, is to keep this fragile body of human beings, all of them, alive as long as possible and as healthy as long as possible. And it's precisely that complexity that not only makes it interesting, it also makes it a little bit disturbing. I think there's a sign of just how hard the task is in the fact that we have a bell curve in medicine. That is, there is a wide gap between the bottom and the top, and furthermore, most of us are grouped in the middle. If you look at results, this is not what the public imagines we have. What the public imagines we have is what I like to call the shark's tail. Meaning, you come through all the years of medical training in school, then you go on to your experience in the clinical setting, in the hospitals, which is yet more years of training. I was just talking to one of the surgical registrars who's describing a 13-year process before she gets to be a consultant. So then surely, after all of this training and experience, we all must have results that are all grouped around the very top of the curve, and that you just have a few outlier stragglers here at the bottom, those crappy doctors at the bottom. And if we were serious about quality in medicine, what we would do is cut them off at the knees, and that would solve the quality problem, right? But instead, what we have is harder for us to acknowledge, harder for us to know quite what to do with, and that's a reality that you have excellent people who work hard, who are conscientious, and get different results. And I want to show you a few examples. This is some data from the United States on hospitals, and it's looking at the timing of antibiotics. One of the steps that we know will produce better results for patients who have a pneumonia and are admitted to a hospital because their pneumonia is severe enough to be in a hospital is that upon admission they should receive a blood culture. They should have a proper antibiotic with its bacterial spectrum, the coverage being the appropriate one. And then you should give that antibiotic within 4 hours of admission. This is data just on the question of how many patients were administered that antibiotic within the appropriate time. And the answer is that it was a median of about 70 to 80% at the typical hospital. But there were a few very interesting hospitals that could do this consistently more than 90% of the time. And then several disturbing groups of hospitals that are at 50% or fewer likelihood that you will get the antibiotic on time. Here are some U.S. national results. Again, risk-adjusted 28-day mortality for newborns in intensive care units. So even adjusting for how sick they are, the survival varies from 6% to 16%, depending on what institution you are. And the median is right there in the middle. It's bell curve. Couldn't come to the UK without having some bell curve for you all, so I took a look, and you know, the truth of the matter is you look anywhere in medicine and look at the patterns of how the results actually turn out, and what you find predominantly are bell curves. And so here is the percent of colorectal cancer patients who have to wait more than 1 month after their GP referral to be seen at hospital. And it varies from a group of trusts that have a less than 10% likelihood that they would have to wait that long, a remarkable result, to 90%, with the median being somewhere around 30 to 40%. What's striking about this is there must be a lesson here. This is not the way we usually think about medicine, right? The way we think about medicine is you do randomized trials and you find out what the answers are about the best way to treat a problem, and then medicine will take care of it. But here is a suggestion that you have different results for people, and this likely translates into at least some effect on survival based on some lessons that probably could be learned from looking at what's happening there, what the patterns are that make that possible. I'll tell you the curve that interested me the most. I mean, I can show you the curves for hernia surgery. I can show you curves for all kinds of different conditions, in vitro fertilization. They're all bell curves. But this is the one that interested me the most, the curve for cystic fibrosis results. And the reason why this interested me is because cystic fibrosis is a condition that in the United States, at least the way we organize the care, it's done exactly the way we all say that medical care should be done. As you all know, this is a genetic disease. It's terminal. The children that are born with this condition end up producing gluey secretions in their lungs that make it so that they progressively lose lung function over time until they die primarily from pulmonary problems. They can also have digestive problems that hinder their ability to gain weight and grow. So in the United States, this care has been organized into 117 centers of excellence, cystic fibrosis centers that are all required to be high-volume centers, so they have high levels of expertise. They are staffed by specialists who are not only pediatric pulmonologists, but have particular areas of expertise in cystic fibrosis. They all participate in clinical trials. They all follow detailed guidelines that have been worked out over decades that are actually much more detailed than we have for most of the rest of medicine. And despite working that hard on the quality of the care and trying to make sure that it can be as consistent as possible everywhere across the country, what do you find? It's still a bell curve. These are the lung function results for patients in these 117 centers. And what you find is interesting. At the median, this 88% of predicted lung function translates into meaning that this is 88% of normal. They're below the normal for people who don't have cystic fibrosis. But up here are 3 centers, or it's actually about 4 centers, where their average patient with cystic fibrosis actually has the same lung function as an average child without cystic fibrosis. And that's remarkable because it translates into the difference between a median survival of 33 years and a survival at this best center of 47 years, a 14-year difference. So if you had a child with cystic fibrosis, you would want to know why. And if you were a doctor starting out in practice like I was when I came across this information, thinking that if I'm attentive and I work hard, that I could be up here at the top, I wondered, how is this possible? What is it that they actually are doing? So one of the things I got to do was visit a hospital that was here right at the median. Actually, it was just below median. It's the University of Cincinnati program. It's a children's hospital in Cincinnati. And I went to the hospital, and they let me come visit. And that was remarkable because I was pretty clear that I was there looking for trouble. I wanted to know why they weren't as good as anybody else. Or more to the point, why they were as good as most, but not as good as the best. And the first thing that's striking about it is that the University of Cincinnati Children's Hospital is routinely ranked in the top 10 of children's hospitals in the United States. This is the place where the Sabine polio vaccine was discovered, the one we rely on for the global eradication of polio. And Tom Boat is the head of the cystic fibrosis program and is one of the best reputations in cystic fibrosis care in the country. He is the one responsible for writing many of the guidelines that we depend on for cystic fibrosis care. And in fact, he wrote the chapter in Nelson's Pediatrics, which is, at least in the US, a kind of Bible of pediatric care for people. And yet there they were in the middle. So I went thinking, that's fine. You have very nice people at the top of the show, but what is it like to actually be a patient in that center? And it must not be all that great. And instead, what I found was care just the way you'd want it. Attentive care. People were conscientious. They had all the technological backup that you could need. And the patients were devoted to their doctors. They felt they were extremely well cared for. And vice versa. The doctors were devoted to them. If you ask me how would I refer someone who called me up to say, my daughter has gotten cystic fibrosis, where should I go? I would say, go to a place that's published work, find a place that's a high-volume center, and a place where people tell you that they are attentive and devoted to their patients. And where that would have led you is here, to the middle of the curve. So then I decided what I needed to do was try to find out what made a place like this different. Because what I thought is if I went to this place, and it turns out to be the University of Minnesota program in Minneapolis, run by a guy named Warren Warwick, that what you would find is they have a secret drug. Because how else to explain why they would be getting better results than everybody else, right? Well, I went to Minneapolis. I got to visit their program. They don't have a secret drug. They use the same treatments as everybody else. They follow the same guidelines, and they get different results. Now, one possibility is that maybe we haven't adjusted appropriately for the sickness of their patients. Cystic fibrosis has genetic variants, and the most severe form is called the delta F508 mutation. And when I asked them about their rates of their delta F508 mutation in their population, they were at least the same as Cincinnati and other programs. And because they get better results, they actually attract a lot of sick patients. So they seem to have actually more of that mutation. When people have tried to study how much of this variability is because of genetics and socioeconomics, education, income, things like that, 25% could be accounted for, but 75%, the vast majority of the variability of where places stand, could not be accounted for by it. And further, it wouldn't explain why at that center you had people who were, on average, getting the same health as people who didn't have cystic fibrosis. So I went down to clinic there as well, and what I found was a place that ran completely differently from places I had seen before, differently from Cincinnati. And it's hard for me to explain to you, except by trying to read a little bit from my book, about what it was like to see a patient in clinic there. Because that's when I started to recognize something that was different, something that might also be possible for all of us in medicine. So in the clinic one afternoon, I joined Warren Warwick as he saw a 17-year-old high school senior named Janelle, who had been diagnosed with cystic fibrosis at the age of 6 and had been under his care ever since. She had come for her routine 3-month checkup. She wore dyed black hair to her shoulder blades, black Avril Lavigne eyeliner, 4 earrings in each ear, 2 more in an eyebrow, and a stud in her tongue. Warwick was 76 years old, tall, stooped, and frumpy looking, with a well-worn tweed jacket, liver spots dotting his skin, wispy gray hair, by all appearances a doddering mid-century academic. He stood in front of Janelle for a moment, hands on his hips, looking her over, and he said, "So, Janelle, what have you been doing to make us the best CF program in the country?" And she sort of muttered, "It's not easy, you know." They bantered. She was doing fine. School was going well. Warwick pulled out her latest lung function measurements. There'd been a slight dip. 3 months earlier, Janelle had been at 109%. She was actually doing better than the average child without CF. And now, she was at around 90%. Now, that was still pretty good, and I knew from looking at the charts in Cincinnati that some ups and downs in the numbers are to be expected. But this was not the way Warwick saw the results. He knitted his eyebrows. "Why did they go down?" he said. Janelle shrugged. "Any cough lately?" "No." "Colds?" "No." "Fevers?" "No." Was she sure she'd been taking her treatments regularly? "Yes, of course." "Every day?" "Yes." "Did she ever miss treatments?" "Well, sure. Everyone does once in a while." "Well, how often is once in a while?" And then slowly, Warwick got a different story out of her. In the past few months, it turned out, she'd barely been taking her treatments at all. He pressed on. "Why aren't you taking your treatments?" He appeared neither surprised nor angry. He seemed genuinely curious, as if he'd never run across this interesting situation before. "I don't know," she said. He kept pushing. "What keeps you from doing your treatments?" "I don't know." "Up here." And now he was pointing at his own head. "What's going on?" "I don't know," she said. He paused, and then he decided to turn to me, taking a new tack. He said, "The thing about patients with CF is that they're good scientists. They always experiment. We have to help them interpret what they experience as they experiment." So they stop doing their treatments. And what happens? They don't get sick. Therefore, they conclude, Dr. Warwick is nuts. But let's look at the numbers. And he still was saying all this to me, ignoring Janelle. He went to a little blackboard he had on the wall. It appeared to be well used. He said a person's daily risk of getting a bad lung illness with CF is 0.5%. And he wrote that number down. Janelle rolled her eyes. She began tapping her foot. The daily risk of getting a bad lung illness with CF plus treatment is 0.05%. And he wrote that number down. So he said, when you experiment, you're looking at the difference between a 99.5% chance of staying well and a 99.95% chance of staying well. Seems hardly any difference, right? On any given day, you have basically a 100% chance of being well. But, he took a step towards me, it's a big difference. He chalked out the calculations. Sum it up over a year, he said, and it is the difference between an 83% chance of making it through the year without getting sick and ending up in the hospital, and only a 16% chance. And now he turned back to Janelle. How do you stay well all your life? How do you become a geriatric patient? He asked her. I can't promise you anything. I can only tell you the odds. Now, in that short speech, I realized, was the core of Warwick's worldview. He believed that excellence came from seeing on a daily basis the difference between being 99.5% successful and being 99.95% successful. Many things human beings do are like that. Catching fly balls, a baseball thing. Manufacturing microchips, delivering overnight packages. Medicine's only distinction is that life is lost in those slim margins. And so he went to work on finding that margin for Janelle. Eventually he figured out that she had a new boyfriend. She had a new job too and was working nights after school. The boyfriend had his own apartment and she was either there or at a friend's house most of the time, so she rarely made it home to take her treatments. At school, new rules required her to go to the nurse for each dose of medicine during the day. So she skipped going. It's such a pain, she said. He learned that there were some medicines she took and some she didn't. One she took because it was the only thing that she felt actually made a difference. She took her vitamins too. Why your vitamins? Because they're cool. The rest she ignored. Warwick proposed a deal. Janelle would go home for a breathing treatment every day after school and get her best friend to hold her to it. She'd also keep key medications in a bag or her pocket at school and take them on her own. The nurse won't let me, she said. Don't tell her. And thereby deftly turned taking care of herself into an act of rebellion. So far, Janelle was okay with this. But there was one other thing, he said. She'd have to come to the hospital for a few days of therapy to recover the lost ground. She stared at him. Today? Yes, today. How about tomorrow? We failed, Janelle, he said. It's important to acknowledge when we've failed. And with that, she began to cry. There are, for the people at the top of their curves for what they do, certain attributes that you discover in the patterns along the way. One, they're not smarter than anybody else. He's not smarter than anybody else. What he is diligent. He understands what it actually means to pay attention to detail. And you saw it in the way that he dug down far enough, not only to learn that she wasn't taking her medicines, but then far enough to see why, how her boyfriend played into it, how the school rules did. And if you think that's diligence, you should have seen what it was like to travel with a World Health Organization physician to the south of India in response to an outbreak of a single case of polio. He had to respond by vaccinating 4.2 million children, arranging for their vaccination, going door to door over a 50,000 square mile area, all of it within 48 hours. Anything less than a 90% penetration of those children in delivering the vaccine would have been a failure of that polio vaccine campaign, of that one response to the outbreak. And they achieved a 98% success rate. Doing it meant understanding how in one village a medical officer was someone you could work with, and in another village a buffoon who you had to work around. In certain places it meant understanding what the electricity was like, and the fact that you had to arrange for ice factories because their ice chest would never keep the cold packs cold enough to keep the vaccine live and working. That was a level of diligence. One of the things you saw in Warren Warwick and you saw in the WHO program is that diligence included being able to have surveillance for failure. It meant being able to see when you fail. One of the ways that he did, you saw, it's a critical way, is that whole visit started with that lung function measurement. He's made that the single most important thing that he measures. And he's done it for 40 years, tracking every quarter of every year whether his children are getting better or getting worse, and asking hard questions with that data when you see the slightest slip downward. Why? Why? What can be done to make you get back on the good track? You saw it in another place that I write about in the book. The U.S. military, and it's also the British military, in Iraq and Afghanistan, have had death rates for soldiers wounded in the battlefield that have dropped tremendously. In the first Persian Gulf War, the death rate matched the death rate in Vietnam and the Korean War, which is 25% death for soldiers wounded in the battlefield. In the current wars in Iraq and Afghanistan, a soldier hit by a bomb, hit by bullet fire, has a less than 10% chance they will die. And this has occurred despite the fact that there is no major new technological breakthrough in how you take care of these patients in the last 15 years. How do they do that then? The answer turns out to be, critically, they have surveillance. They have on a weekly basis publicly announced how many are wounded, how many have survived, and then having announced that, they've asked hard questions about why is the survival rate where it is? Could it be low? Could the survival rate be higher? So pressing hard and looking at the data and being statistical about it, they've discovered that soldiers early on were coming in with heart and lung wounds that the Kevlar armored vests should have stopped. And that's when they discovered that the soldiers were coming in not wearing their Kevlar. And so they passed a rule holding commanders responsible for making sure that the vests are worn, even if it's 110 degrees outside and the soldiers complain about the heat of the vest, even if they don't like the 18-pound weight. And you saw the number who are dead on the battlefield dropped. Then they found that the transport times to get them to the operating table were too long. And they were losing people along the way. And so they moved surgeons and their teams out onto the battlefield, right behind the troops. The surgeons complained about this. They said, how can we possibly do our job without the technologies that we need to have from the hospital? The orthopedic surgeons, for example, had to go in these tent facilities without any x-ray equipment. Now, what orthopedic surgeon thinks they can do their job without even a simple x-ray? They had to find the fractures by feel. But tracking the statistics, the advantage of having someone on site ended up lowering the death rate. And the results, and these are just a couple of the dozen, many more than a dozen in fact, small adjustments they've made that have led to the lowest death rate in history. We are saving people from injuries that have never been saved before. People who have lost 3 limbs, people with brain injuries, and now our hard task is, can we reclaim for them a life? But having made this, come this far, we can think in much the same way about how to produce those better results. So one of the attributes I said is diligence, and diligence includes being able to monitor and see when you're failing and when you're succeeding. A second is a kind of moral clarity about our mission, understanding that what we do is a moral task, and that it comes with obstacles along the way. So Warren Warwick is someone who has to deal with our American insurance system. That was a 20-minute visit that I described, which is what you get reimbursed for under the American system. And we all function under financial pressures of having to do what we have to do. He is someone who knows that he will not be reimbursed for some of the things that he does. And so he works around the system. He finds ways that he has to do it to make it work. And if it's a child that he has to put in a lot more time into, then he will when he has to. But he also is someone who recognizes that if his unit loses money and goes bankrupt and has to close, he will not have saved children's lives. And so his struggle ends up being as much with some of the impossibilities of the systems we work in as it is in taking care of that one person then and there. And then there's a final attribute, which is an attribute that I think is part of what makes being in medicine very special nowadays. And that's the chance to exercise what I've called a kind of bedside ingenuity. And you saw it in the way that, yes, there are protocols, there are algorithms that he has to follow that we all want to learn and follow. And yet within that, he could have that kind of ingenuity where he recognized keeping Janelle on the forward track could involve coming up with that idea of having her keep her own pill in her pocket. And how that could become a kind of way of saying, look, take the medicine yourself, ignore the nurses, and translate that into a kind of rebellion where this time she was rebelling in a way that would actually put her back on a path for survival, for saving her own life. You also saw it, though, not just in how he was as an individual surgeon, individual pediatrician with that individual patient. You saw it in other ways. He's one of 8 pediatric pulmonologists in his unit, one of about 10 to 12 nurse practitioners. There are social workers, there are nutritionists, and if he does a fabulous job and everyone else does a mediocre job, they will still be in the middle of that curve. And so he's also been ingenious, had a kind of bedside ingenuity for figuring out how he gets everybody to produce better results. So one of his innovations is simply to have a meeting once a week where everybody in his unit has to describe the patients they've taken care of that week, what problems they had, and what solutions they've given them. And imagine if you as a patient went to see a doctor and you got not only the benefit of their wisdom and experience, but the benefit of the entire division's experience. And I think that's a huge part of why they've all ended up pushing their results up the top of the curve. There are scientific innovations he's made. He's come up with a vibrating vest that can shake the secretions free for a child with cystic fibrosis. Turns out to be better than the parents beating on their back, which was a British innovation that helped in the 70s, helped children live a lot longer than they did. He's thought hard and obsessed about what he could do, knowing the results, to make them get better. Well, thinking about it in this way, thinking about the bell curve and its shape and where we stand on the bell curve, I think it gives us some thoughts about how we change what we do. I'm a surgeon, so let me try to think of surgery as one example. We do in the United States a little over 35 million operations a year, and I actually looked up before I came here, you do in the United Kingdom about 6.5 million surgical procedures per year. Our complication rate for surgeries is around 3%. In general surgery, it's about 10%. If we wanted to ask ourselves the question that too few of us ask, which is, how could we lower that complication rate? How could we say, cut it in half? We actually aren't very well equipped to answer this question. It's not a medical question. It's not one that we think of being a mission. We want to know what new technologies we can come up with, what new surgical procedure, what disease I can solve. But not this question of how can we make it so that we actually get better results in the real world. And I tried to think about what a model for some of this might be. And there is one field in medicine that has high risk, that had poor results, and set about trying to produce better results, and actually did it. And a woman who was extremely important in being able to contribute to this was actually a surgeon, though most people didn't realize she was a surgeon. Does anybody know who this woman is? It's Virginia Apgar, who is the originator of the Apgar score. In 1937, she was the first woman graduate from the Columbia University Surgical Residency. And Alan Whipple, who was the chairman at the time, told her, forget it, Virginia. No one is going to send a patient to a female surgeon. So she agreed to take a job on the faculty as an anesthesiologist, which was at that time a lower status profession. But you have to understand a little bit about Virginia Apgar. She is the sort of person who was not about to stand for it staying that way. She was tall and imposing, though you couldn't tell it from the bobby pins. She's the sort of person who would, whose motto was, do it right and do it now. She used to carry around a length of tubing and a knife in case she had to give someone an emergency airway, and actually did it 12 times in the course of her life. She not only was a master violinist, she used to design and build her own violins and violas, and would steal wood from the walls around the hospital that she thought looked particularly good. At the age of 59, she got her pilot's license and flew illegally under the George Washington Bridge in New York City. She is someone who was not about to let an anesthesiology stay a low status profession, and within a couple of years had turned it into its own division, and then helped set it on a path that turned it into its own department. And then having done that, she took on a new problem. She was interested in understanding why children were dying so frequently in obstetrics. Her favorite area of anesthesia was obstetrical anesthesia. And what she saw was that children would be born who were too small or had a birth defect, and they would be set aside, and the parents would be told the child was stillborn and it would be left to die. And she was convinced, not that the doctors didn't know what they're doing, not that they were mean or bad, but that they didn't recognize that these children actually, more of them could be saved than they knew. She wanted to show that you could improve the outcomes in obstetrics, but how could she do it? She was a woman in a man's world, and she was an anesthesiologist in trying to make a change in how obstetrics worked. So what she did was very sly and psychological. She came up with a score. The score rated the health of children from a 0 to a 10. And that rating, if you have a score of 9 or 10, meant that you were born pink and healthy and screaming with your lungs and your heart and everything working well. And what she noticed was that for the children who were born with a score of less than 5, this was where all the neonatal deaths were concentrated. These were children who were born blue and limp. This became very powerful and very quickly. It became powerful because, number one, it forced them to look carefully at the children. It forced them to say, okay, I will observe their breathing, I will observe their crying, and rate them. Second of all, by having an outcome, we're all very competitive people. We don't like to have a lot of children born with low scores under my hands. And the doctors began asking, well, how could I get better scores? And then this is a simple enough outcome that it gave them immediate feedback on how they were doing. And so she recognized and showed that general anesthesia depressed the breathing of children, and they would be better off with spinal anesthesia and later the innovation to epidurals. It ended up showing that routine ultrasound could detect problems before birth, and that became a routine standard. You saw within, this is 1958, and by 1960, neonatal intensive care units were popping up all over, not only the United States, but Europe and elsewhere, because you could rescue children with a poor score and take them from this high chance of death and lower that likelihood of death. This is not a randomized trial. What it was a target that everybody could aim for, that people generally agreed on, made clinical sense. You could put science and protocols into it, and it also had room for the art of medicine. That is, it would take dozens and dozens of steps. But where have we come? We have 4 million births in the United States. There would have been approximately 20,000 perinatal deaths if the statistics of this era held to today. And instead, it's roughly about 1/10 that number. Surgery, on the other hand, our complication rates have not changed enormously. So in our research group, what we've tried to do is think about whether we could do something like Virginia Apgar has done. So in February, we published our first results of just taking records from an anesthesia chart recorded during surgery. Turns out there are 38 different data elements on a standard anesthesia recording form that you could then ask, how many of these predict whether the patients are going to die in the next 30 days or have a major complication? And a bunch of them are predictive, but there were 3 that were the most powerful. Number 1 was the amount of blood loss. Number 2 was the lowest mean blood pressure, mean arterial pressure. And number 3 was the lowest heart rate. So that the patients who had a score of 9 or 10 meant that they had a less than 100 cc blood loss, had a mean arterial pressure of greater than 70, and had the lowest heart rate getting down to at least below 65. And when we looked at our results, what we found was just like Virginia Apgar, the deaths were concentrated in the scores of less than 5. A score of less than 5 meant a 16% chance of death and a 60% chance of a major complication. A score of 9 or 10 meant a less than 4% chance of a major complication. And now we've used this in close to 8,000 patients in 2 different hospitals, and we've only had 2 deaths in this group. So then, trying to think the way that Virginia Apgar has, we've started to present numbers to our own surgeons in our unit. This is just from a recent compilation of our data that we gave to our unit of 1,300 patients. We had about 3% of our patients who had scores of less than 5. And of those patients, we pulled the charts for about half of them and just tried to look for some basic patterns. We started to notice some things. 1 out of 5 who should have gotten a beta blocker prior to surgery didn't get the beta blocker. We found when we asked the surgeons, a lot of these cases involved a blood loss of greater than a liter. They were very complex cases, large tumors, for example, sarcomas. And when we asked the surgeon, we said, did you know in advance that this could be a case that loses a liter of blood? And they said, yes. But then you look in the records, and what did the patients have for their IV line? A small 20-gauge single IV, which is the sign that the anesthesiologist did not know what the surgeon knew. And so there had been a breakdown in planning where, you can take someone who loses a liter of blood but keep them stable enough to get better scores and better outcomes. We also recognized we were sending under protocol some patients to the intensive care unit after a Whipple or other major abdominal surgery who didn't need to be there. And so we could plan on how to think of using our resources more efficiently. The point here is not that we've found the answer to how to make surgery safer. The point instead is that, in a sense, we need an APGAR score for everyone. If obstetrics has a way that you can just very quickly recognize when you've succeeded or failed for a child, why after a psychiatry visit couldn't we have that same way? Or for a pneumonia patient admitted to the hospital, or for a surgery patient. One of my favorite essays in the world is by Samuel Gorovitz and Alistair McIntyre, 2 philosophers, and they wrote in the 1970s on the nature of human fallibility. And what they pointed out was that, in essence, there are 2 sources of fallibility or error in what we do as human beings. The first source is ignorance, meaning that we err from a general lack of knowledge of all the particulars of the ways the world works. But the second source they called ineptitude, meaning that the knowledge is there, but an individual fails to apply it correctly. The revolution of our time, of the era we live in as human beings, is that even just 2 generations ago, the major failing of mankind was ignorance. We didn't know what to do for someone who had a heart attack. We didn't know how to prevent it. We didn't know what high blood pressure really meant. We didn't know how to control it. We didn't know how to treat most infectious diseases. Fast forward to today, we have 6,600 different drugs available to us. We have hundreds of surgical procedures. We have dozens of ways you can go about making a diagnosis. We have a gap, though. Having discovered all of this, do we actually deliver it? Do we do it consistently? The bell curve tells us we don't. We have a wide variability in the results that people get with that know-how. In a sense, there has to be a science to discover what these folks know, what it is that really happens in performance. There are growing pains. This is a new field. For all of us, it was a real pleasure to see Sora Darzi's unit and the safety unit at St. Mary's, because it is a pioneering center, and you have dozens of young people who are trying to think hard about why some people succeed and other people don't. We have a handful of centers in the United States doing this, but I can tell you it adds up to maybe 40 or 50 people working and thinking hard about this. And what we want is some way that every physician thinking every day about what they do can recognize when they're succeeding, when they're failing, where they stand. It's going to require transparency about our own results, a willingness to compare ourselves to others and think hard about whether we're getting better or not. That makes us uncomfortable, but it will be where we have to go. I think also that the other remarkable thing about medicine is not only that it's hard and that there is a bell curve and there's a science to understanding how we make it better, It is the fact that because this is our most ambitious endeavor as human beings, that this level of complexity in medicine can give lessons to other people in other fields as well. If we think we haven't come to grips with how to recognize our human failings and why we do fail, think about how other human professions do. Teaching, the legal profession. I think there are lessons coming out of medicine that can shape the entirety of how we work and function with all the knowledge that we're now accumulating over time. And that is our special opportunity. I want to thank you again for getting to be part of the centenary, and if there's time for answering questions, I will be more than delighted.
You've been listening to a special lecture vodcast from Imperial College London.